Hi, welcome back to Gemma Network Open Live. I'm Seth Truger, Digital Media Editor for Gemma Network Open.
And I'm Mike Berkowitz. I'm the electronic editor for Gemma and the Gemma Network.
We were off last week for the July 4th holiday, so we got a special episode today. We're just going to do one paper. We've got the author coming right up, and then we're going to do 2 weeks worth of the table of contents rundown, and then a special House of God preview at the end.
Awesome. That sounds exciting.
Right. So first, most importantly, we've got our author, Dr. Dawn Bravata, who is going to talk to us about her paper, The Processes of Care Associated with Risk Mortality and Recurrent Stroke Among Patients with TIA and Non-Severe Ischemic Stroke. So welcome.
Thank you.
Great. So why don't you tell us, what do you do in the paper?
Well, the objective of the paper was to identify processes of care that are associated with improved outcomes for patients who've had either a transient ischemic attack, a TIA, or a minor stroke. And the background for this is that several studies have shown that interventions that provide timely care for TIA or minor stroke patients can really dramatically reduce their risk of adverse events. But those studies have all varied in terms of the exact processes of care that were delivered to the patient. So we wanted to know what were the critical processes that all patients should receive who've had a TIA or minor stroke. That was our objective.
Great. Yeah. So it looks like you looked at VA data for basically all patients in the ED or inpatients who had TIAs or minor strokes, roughly the year 2010 to 2011. Found, was it 8,000 patients? Where is it? About 5? I've lost my numbers here. But
yes, so very. Yeah.
Go
Yes, no, so that's right. And we looked at 28 different processes of care. So I would say a strength of the paper is that we examined a broad set of processes of care. Some were diagnostic, like brain imaging or carotid artery imaging. Others were sort of risk factor modification, like management of atrial fibrillation or hypertension or statin use, that sort of thing. And then what we did was we examined each process of care after very carefully risk adjusting for patient characteristics. So that's the sort of methodologic sort of strength of the paper, if you will. And one of the things that we did that I think is kind of important is that we examined a specific bundle of processes of care, because we think that for some patients, they're not going to just get 1 or 2 processes, they're going to get like a whole set. Mm-hmm. And so we defined the without fail care rate as receiving all of the processes for which a patient was eligible among 6 key processes. And we picked those processes because those were some of the things that had been provided to patients in those prior studies that had demonstrated dramatic improvements in outcomes. So those 6 processes are things that could be provided at pretty much any hospital in America. They are not requiring specialized structures of care. They are brain imaging, carotid artery imaging, care for hypertension, making sure a patient has an aspirin, making sure patients are receiving high or moderate potency statins, and I think that's it. Did I name 6? So, pardon me?
Yep,
you did. You're good.
Yeah. And so the key finding is that if you provide without fail care, you can reduce the risk of mortality at 1 year. So that's the sort of main finding, if you will.
Yeah, I was surprised. Only 15% of patients received all 6 of the without fail care.
So that's not technically accurate. So it is correct to say that 15% of patients received without fail care, which means that 15% of patients received the care for which they were eligible among all 6 processes. But for example, if you don't have atrial fibrillation, then you don't need anticoagulation. And the without fail care measure is actually a very hard one to pass, because if you're eligible for 5 processes, you have to get all 5 processes. They have to be done in a timely fashion. All of these are sort of, with strict time constraints. And so it's a very hard measure to pass, and it's a really very high bar, if you will.
Right. I'm wondering.
I would like to comment though on that 15%. So that is the national rate in the VA in fiscal year 2011, as you've said. And sort of the good news story is that the VA has engaged in quality improvement interventions for TIA, and so that without fail rate is actually much higher now. And in sites that have implemented TIA quality improvement, it's actually 57%. So it's actually really made a very dramatic change. And that 57% without fail rate a lot of people are more used to thinking about what proportion of care did patients receive, and so that actually translates into a 90% pass rate on those 6 processes of care. So that's actually, I think, like super fantastic news for the VA as a system.
Right, and they typically meet those assessments of quality for guideline concordant care across a lot of conditions. Just a pitch for the VA. I spent a lot of time there earlier in my career. I was wondering whether there were differences between your findings if you looked at the subgroups by TIA versus stroke, because theoretically TIA is a stroke, right? But practically, if you see a TIA in the ED, and you can maybe speak to this more than I can, you're not managing all the risk factors out of the ED. You're kind of discharging them with, acute care, maybe giving them an antiplatelet agent and saying follow up with your neurologist within 48 hours or something. So I'm wondering whether if that figured in at all to your findings, or whether you looked at those differences.
Yes, so that's a great question. So the background for why we did this project was that a much earlier project where we did benchmarking of quality of care for stroke in the whole VA demonstrated that actually the stroke care quality was higher than the TIA care quality. And that was the impetus for doing this. Stroke care in the VA it's like this wonderful story. They have reorganized care. And so now stroke care in the VA is provided at a very exceptionally high level of quality. Unfortunately, there were gaps in care quality for TIA. That was one of the reasons we did this study, because what we wanted to do was to identify the critical processes of care that then would serve as quality improvement targets, and which is exactly what's happened. We've developed quality improvement programs based on those without fail measures, and sites that are working on those without fail measures are improving quality.
Great. And you're getting at another question. These are from 2010, 2011. So the VA has upped its game in terms of stroke care and presumably endovascular perfusion and stuff. So I'm wondering if you can talk about the relevance of these older data to contemporary VA and other practice.
Yes, thank you. So I would say that although the quality of care has changed, the question at hand was still, what are the most important processes of care, meaning which processes of care were most robustly associated with recurrent stroke or mortality. Those data are not,
Right.
They are unlikely to change. And in fact, it's an advantage of using the slightly older data, because one of the limitations of the study, even though we had over 8,000 patients, because the pass rates for some of the processes were quite high. So, for example, most patients are getting aspirin. And so our ability to really examine the difference in outcomes among patients who get aspirin or don't get aspirin are limited if you have really exceptionally high pass rates. And so it's actually a strength that we had some diversity in terms of, opportunities for improvement on some of the processes.
Yeah, I want to welcome a couple of our new viewers. We've got a bunch of people who joined us. Dr. Mamakai, Dr. Deard, apologies for my pronunciations, and Dolphin Defender. Unsure if you're a doctor or not. But of course, if you've got questions.
But a defender of dolphins.
Yeah, absolutely. Aren't we all, though, to some degree?
Yes.
So, of course, chime in with questions or comments if you have them. Mike, your point is perfect because it segued into what I wanted to talk about.
Okay.
So it's interesting to me, both from what I've seen at the different hospitals I worked at and as well as the literature I've read about it, where there's a huge variation of what happens to TIA patients, basically mostly based on what seems like local institution preference or style pattern, as far as do TIA patients see neurologists in the ED? Do they get discharged for advanced imaging? Do they see neurologists as an outpatient? If I remember correctly, I think it's Denmark has this great network of outpatient TIA clinics where they get it all done and get discharged. A lot of places will admit patients for TIAs just across the board, and it's just there's a huge amount of variation, which is what's interesting to me about this paper, because looking at really the timing and what was necessary for patients to get. What I was most surprised by here was that the positive signal for mortality benefit in seeing a neurologist early on, because that to me, from my point of view, it makes sense. If you get the services you need, you get your neck vessels imaged, you get your head CT, you get an echo at some point. Do you need to be in the hospital? Do you need to see a specialist? But there was this big signal for benefit for seeing a neurologist within 24 hours here.
Yes, so I agree. That's a really important finding. And it's one that is super frustrating to general internists, because everybody wants to know, what is the magic that the neurologist is doing, and can't other people do what neurologists do. And I will just say that there is a robust literature about improved outcomes among stroke patients admitted, stroke patients in particular, by receiving neurology care. And so this is not the first study that has demonstrated the benefits in terms of outcomes of receiving neurology care. I will say we examined a few kind of characteristics to sort of see if we could understand what was going on with the neurology care. So, for example, is it because you're more likely to get a neurologist if you're admitted? Is it because you're more likely to get a neurologist if you come in during the week as opposed to nights or weekends? And in fact, it's really the receipt of the neurologist and not those other characteristics that's the key driver of the outcomes. And so we are left with this impression that it is fundamentally important for TIA minor stroke patients to get early neurology care.
But I'm going to pitch that back at you and say, isn't the neurologist the practitioner most likely to order all the guideline concordant care? I mean, we could make a countervailing argument, but doesn't that person have in their bag of tricks carotid imaging, brain imaging, antihypertensive intensification, and so on? So is there a correlation between that variable and the others that are thought to be, guideline concordant processes?
So yes, you are quite right that patients who receive neurology care are much more likely to receive all of the other components of care. However, patients who are admitted are also much more likely to receive neurology care. And actually, patients discharged out of the emergency department have much greater disparities in quality than if you examine. So what I'm saying is much lower quality if you're discharged out of the emergency department compared with those who are admitted, that those disparities are greater than the differences between those who receive neurology versus those who do not receive neurology. And so you are quite right that neurologists do have in their bag of tricks ordering those things. I will say, though, one of the things that neurologists are kind of hesitant to do is hypertension management. And that was something that we followed in the post-discharge period, right? So that's one of the processes that actually extends into the primary care area. And so so not all of the processes are fundamentally delivered by neurologists.
That's really interesting. I mean, there's a borderline policy implication that that specialty should be training their folks within the entire armamentarium of antihypertensives if that's going to be part of their treatment.
And I'm curious because obviously this is my anecdotal experience, but
it
seems to me from what I've seen in casual conversation with a neurologist about this is there's neurology. It's not that neurologists are failing to or don't want to control hypertension, but this I think physiological debate about is managing hypertension down, decreasing perfusion pressure in the brain, and basically is it how do we thread that needle there?
Right.
I don't know.
I'm so glad you mentioned that because neurologists are rightfully quite hesitant to manage hypertension in the acute event period.
Mm-hmm.
But what we were looking at is at discharge. It's in the post-discharge period, and so we should just be very clear that there is no controversy that in that post 72-hour period in the outpatient setting, people's blood pressure should be managed to target, and that is a key process of care. So I'm so glad that you mentioned that.
Yeah.
And I do agree with your policy implication. Neurologists should feel comfortable managing blood pressure. Many of them receive an internal medicine sort of internship year, and they should be empowered to use those skills.
Mm-hmm. Awesome.
Yeah. I'll say the last thing I want to say, I don't want to take up too much more time, is I found it interesting how much more of a signal there was towards mortality benefit than stroke reduction benefit here.
Yes, I agree. I was really surprised by that as well. And you are quite right that the mortality benefits were astonishingly large for many of the processes, including for receipt of neurology care. So I agree with you. We were all surprised by that.
Yeah. So my main takeaway is if you don't see a neurologist, you're all going to die.
No, that is not the takeaway. But we should embrace our colleagues and the neurological specialties and invite them into the EDs and into our wards.
And we do. I will tell you, our neurologists are not shy or, I don't know, don't spend too little time in my emergency department.
Okay.
Right. Well, thank you so much for joining us. It's been great.
Thank you.
It's a great paper, and thanks for submitting it to JAMA Network Open. We love talking to you.
My pleasure.
Thanks. Take care.
All right. So next,
What's up?
We're going to move into a massive table of contents list and blow through a bunch of things at rapid pace.
Is this a data dump?
This is a data dump.
Okay.
So we're just going to run through basically three releases, tables of contents, starting on June 28th. There's a great edit. I usually don't talk about editorials here, but there's a great editorial that talked about 5 different gender disparity papers that have been at JAMA Network Open since I think as far back as October, looking at gender diversity industry payments to radiation oncologists, female authors of perspectives in top pediatric journals, women speakers at conferences, gender equity and salary and promotion, and I think we talked about the one on linguistics in resident evaluations of faculty.
Lots of interest in this topic in terms of getting woke about gender differences in our profession.
Yeah, and the bottom line is I am just so fascinated at how much evidence there is of gender disparities and how many mostly male physicians just kind of refuse to believe that a problem even exists.
Okay. But what does the editorial say? Is that what the editorial says?
That's what I said. That's me editorializing. I don't want to put words in their mouth.
There was an editorial, and
there was an editorial that talked about all this stuff. You should read it.
It really just kind of summed up because these papers were kind of dripping out on a fairly irregular or regular basis, and this kind of pulls them all together in one place and connects kind of them thematically through the editorial and kind of sums up what where we are in the field. Yep,
it's the double-edged sword of being a multi-specialty, multi-interest general medical journal that is online only.
Yes. Okay.
All right.
What's up?
Next up, still on the topic of equity, big paper that looked at trends in health equity from 1993 to 2017 using the CDC BRFSS data. Basically, they asked a whole bunch of people in a survey, did they have in the last 30 days about their physical and mental health? How many healthy days do they have? The good news is the black-white gap is down. The bad news is that measures of justice and equity, justice being the correlation of outcomes with income, race, and sex, and equity, which was this complex measure summed up into one number on equality and disparities, both of those are getting worse.
Good. Yep. So this is kind of a population epidemiology study that characterizes differences between these 2 years, 1993 and 2017, as Seth said. And I wasn't quite sure what to make of these kind of very high-level data, particularly because things kind of came out of the statistical wash as being statistically significant, but at small levels, and I wasn't sure what scales we're talking about when it comes to health justice, for example. Income disparities were up. And health disparities were down, but health justice was down too. Yep. So it just seemed like a dashboard with needles going in a few directions. So I think the research needs to figure out what it means.
Yeah, as both a lumper and an emergency doc, which probably go together pretty well, I think there's still lots of opportunities for improvement in all these domains.
You're optimistic, I hear.
Still a little bit.
Okay.
Next up, trends and characteristics of patients with newly diagnosed cirrhosis. So this is more research from Indiana. They looked at a network of a decade's worth of new cirrhotic diagnoses, 9,000 new patients. And interestingly, there's increasing rates of cirrhosis in patients under 40 and an even bigger increase in patients over 65, which probably overall goes along with boomers, hep C, alcohol use, et cetera. But most interesting to me was there was less viral hepatitis. The graph is basically dropping down, but more alcohol cirrhosis and more NASH, or non-alcoholic steatic hepatitis.
Right. And to my reading, the authors attributed the rise in cirrhosis in younger folks to alcohol use and the rise in cirrhosis in the older set to the costs of obesity over a number of years.
Yep, exactly. And it basically looks like the non-alcoholic fatty liver disease is just becoming more and more of a problem in America, unfortunately. Again, more opportunities for improvement, unfortunately.
Yep.
Next up, another not so happy paper. Of course, we're required to talk about opioids. They looked at all 3,100 or so U.S. counties and looked at the rates of opioid use overall, the overdose mortality, as well as the low capacity to deliver treatment. So basically, what were counties that didn't have any opioid treatment programs or no providers who were licensed to prescribe buprenorphine. 24% of the counties had very high rates of overdose. 46% of counties lacked a provider overall. 71% of rural counties didn't have any opioid use disorder providers at all. The highest rates of the mismatch here were basically there were high rates of overdose and low rates of providers were in Appalachia, the Mountain States, and the Southern Atlantic region.
Right. And what was surprising to me was kind of up towards the top of the paper in the descriptive data with that map showing overdose rates. Now, it's independent of the variables of the exposure variables, which was providers and distance and things of that sort. But we think we're fed in our political moment with this notion of bi-coastal elites, and there's a huge amount of overdoses in Maine, Vermont, Massachusetts, Connecticut, what we think of as the blue, very wealthy states. They're also in Ohio, West Virginia, and Kentucky too, which is kind of the stereotype of opioids in our country. But I found that surprising. That was new to me.
Yeah, and it's interesting to me. I mean, I think I have an ongoing theory that there aren't blue and red states. There are blue cities and red not cities, and each state is basically the balance of how those balance out. I grew up in New Jersey in the New York suburbs, and you very quickly go from urban to nice suburban to
Exurban
plains, to exurban,
to the Meadowlands.
I mean, and then half of New Jersey is farmland and forest.
Right.
That's incredibly rural very quickly.
Right.
There was a cow. I mean, I grew up in the suburbs, and the first house I lived in, there were still my neighbors had cows.
Oh, really?
And not ironically, not in a weird hipster way.
Fresh milk with Bordetella.
They did not give them to us.
Okay.
All right. Next up, this is an interesting one going back to cities. So they looked at ambulance use in New York City before and after the Affordable Care Act implementation in 2014 for minor injuries. So basically, were people calling for ambulance dispatches for minor injuries more? The top line number is yes. There are more. There's a 37% increase in EMS dispatches in New York City, basically right after the Affordable Care Act implementation went into effect, which sounds like a big number, but those accounted for less than 1% of overall ambulance dispatches. Basically, it went from about 20 minor injury dispatches to 33, but that's per EMS unit, and there's 31 of those in the city. And then the non-minor injuries, so injury or major injury, was 550 to 560, and basically their estimate was there were 2,900 more minor injury ambulance dispatches per year, but that's out of about 1.3 or 1.4 million per year. So yes, with lower cost, it seems that with lower barriers to care, lower costs, et cetera, people are using it more. There's also, I could talk forever about how hard it is to get preliminary data such as triage or dispatch data to final diagnosis, and especially in low acuity stuff. But it's certainly interesting.
Yeah, I guess that gives a new meaning to there's no such thing as a free ride.
Yep.
I mean, in this instance, a lower cost ride led to greater use of the services. It was still a pretty low proportion of overall dispatches, but people were using it probably for things best left to other forms of transportation.
Yeah, welcome a few more viewers, including Saad bin Abdullah and, of course, Kedamin. Welcome back, Min.
Our friend Min. Hi, Min. Thanks for joining.
Speaking of Twitter friends, the invited commentary was written by one of my Twitter friends, Surafel Sega. I'm sure I'm mispronouncing your name, and Huang Cho, who are docs in New York serving underserved populations, and have a great discussion kind of on the other side of what the paper is showing, that things like giving patients more skin in the game or out-of-pocket costs when vulnerable patients already have big barriers to get into care, including transportation to care. These scary-looking 37% increase probably is, there's many more things we can do than worry about people overutilizing ambulances, basically.
Thanks for writing for the paper, for the journal.
Great. Next up, you're going to have to talk about this one because I don't understand most of the words here.
Sure. So this is association of titin truncating genetic variants with life-threatening cardiac arrhythmias in patients with dilated cardiomyopathy and implanted defibrillators. So that is the title that felled our colleague, Dr. Seth Truger. So titin is a structural protein in myocytes, including cardiomyocytes, that can be considered to be a molecular bidirectional spring, according to the authors. It's basically a structural protein in muscle, and you get genetic variants, and therefore you get a different form or a dysfunctioning form of the protein, and that has been shown previously, as I understand it, I'm not an expert in the literature, to be associated with dilated cardiomyopathy, but these authors were also asking, in patients with DCM, is it also associated with life-threatening ventricular arrhythmias, VTVF, and also persistent AFib? And to cut to the quick, they found that association, and these were patients who already had implanted defibrillators, so they had presumably an event and were at risk for future events. They were unable to identify a mechanism that's actually going an extra half step to try and figure out whether they could see any other kind of radio markers of the association. They looked at kind of myocardial wall fibrosis and didn't see any association between these genetic variants and this ultimate disease in these patients. But it moves the ball or the needle a little bit forward in terms of understanding a possible mechanism underlying these disorders that we see in a lot of patients.
Right. Yeah, and I think there's also some clinical value here, potential for patients who, a lot of patients with heart failure probably benefit from getting ICDs placed. A lot of them probably don't, or are in fact too sick to benefit from it. The basically dangerous procedure of getting an ICD, it's expensive, et cetera. You need sedation to get something plugged into your heart. And maybe at some point in the future, testing for this genetic variant might help make, decisions at the edge cases.
Right. And going off the reservation, you can consider gene editing or gene therapy to correct this structural variant. But that's probably past my career.
Yeah. And they only had 120 patients, but it was a pretty decent difference of 46% versus 26% of ventricular arrhythmia, which is, pretty high. That's a number, an absolute risk difference of 20%, 1 in 5. That's huge.
And before you go on, I'm going to correct something I said. I talked about fresh milk and Bordetella. That Bordetella pertussis, fresh milk does not give Bordetella pertussis. It's brucellosis that I was thinking about. So just want to correct the record. What do you have next?
All right, that's peer review in process.
Yes, right.
Real time. So next up, back to the inequities. We're now in the July 3rd release. So the changes in perception of discrimination in healthcare in California, 2003 to 2017. They used data from the California Health Interview Survey, had about 84,000 participants. Asked them the question, was there ever a time when you would have gotten better medical care if you had belonged to a different race or ethnic group? And I think that was in the last 5 years, the way the question, they compared results from 2003 to 5 to 2015 to 17. The good news is the rate's decreasing from about 6% who said yes to 4% who said yes, which is good. Also, those numbers are much lower than I would have expected. Overall, the improvements were best. The biggest improvements among Latino immigrants and patients with low English proficiency, but rates of reported perceptions of discrimination remained high in African American and Asian Americans.
Right. So it's the vulnerable populations who are imagining better care if they were someone different.
Yep.
Okay.
Yep. Yep. So interesting stuff. Again, slow march of progress, but lots of opportunities for help.
Right.
Next up in our this will be in the next issue of the gender bias editorial, I'm sure, is quantifying sex bias in clinical studies. So they used automated data extraction to look at 43,000 papers and 13,000 clinical trials of various diseases, going all the way back to 1966. And basically compared the numbers of female participants in the studies to the demographics of the patients who actually have the disease prevalence. And not surprising, there's disparities there. There's fewer women in studies than there are women with disease, but there are some slight improvements over time.
Right, and we just published a similar paper, not to take the focus off this, in JAMA Oncology in association with ASCO in early June, showing a variance in the age. We may have even talked about this in a previous broadcast, that clinical trials tend to enroll younger patients with cancer so that they're not fully reflective of the true patient populations we're caring for. And this is the case across clinical trials over 50 years with regards to sex. And I think this is as much a research methods paper as it is a kind of a clinical trials paper, because it's the automated data extraction that in some ways is the advance. To be able to set the computers on this and to get that information out is an accomplishment.
Yeah. Speaking of computers taking over, the next paper is they developed and validated a machine learning algorithm to use to evaluate clinical notes from the first 24 hours of inpatient psychiatric admissions, just kind of the routine data in the normal notes to see if they could estimate the risk of violence from those patients in those inpatient units over the next 4 weeks. And it was modestly accurate.
So patients in the ED, and I'm assigning this to see whether they're going to get violent upstairs?
Yeah.
Oh, that's interesting.
Yeah, and it's...
Is it psychiatry or all patients anywhere?
I don't remember. Sorry.
Okay.
But these were for patients with mental health problems and mental health admissions.
Right.
Which to me makes a lot of sense, especially because most patients aren't violent in inpatient psychiatric units. The tools that we generally have to prevent violence or to fix violence are generally pretty big tools to use, like chemical sedation, mechanical restraint, et cetera, or physical restraint. So the more tools we have to be able to predict and right-size care, the better.
Right.
Yeah.
Okay.
All right, more bias. So this is from another Twitter friend, Dr. Argaban Solis, or Sales. Apologies for my mispronunciations. Estimating implicit and explicit gender bias among healthcare professionals and surgeons. So they took data from the implicit association test. Have you ever done one of those?
I have, but not with regards to healthcare. But
Right.
why don't you describe to viewers what it is?
So in general, there's tests. These are supposed to test what your I don't know your
It's a reaction time.
yeah, reaction
really.
test. So like it shows you pictures of people with different color skin or different words, and you have to basically very quickly hit like a positive or a negative button, I think, or something like that. And basically based on how long you process, how many mistakes you make, how many times you put, say, a white person versus a person of color in the good or bad basket. It's supposed to be an indirect measure of our implicit biases.
Right, it's pre-conscious because I think what they're testing is this congruity between an image, say a person of color, in a word with a positive value or a negative value. And if people take a little bit longer to react to that, to the difference, you can kind of read out some of their implicit biases that they wouldn't endorse on an actual survey or otherwise admit to.
Yeah, so they took 131 surgeons and then did this with basically some gender and work things in healthcare. And not surprisingly, men were more associated with terms like career, women more associated with family. And when it came to actual healthcare stuff, men were more associated with surgery and women with family medicine. And obviously there are women surgeons. That is a thing now. It's the future.
Right.
But there are still lots of biases and much more work we can do to gender equalize.
Right. So there are still career stereotypes among male and female physicians about male and female physicians.
Yep, absolutely. Right. Good, well put. Next up, moving into policy realm. So this is a complex paper looking at the 340B program, which very briefly is a federal program that's supposed to subsidize docs and hospitals who provide care to underserved patients. This is looking at 340B in the Hep C drug treatments using Part D Medicare Part D claims for prescription drugs. Notably, for background, 40% of Hep C drugs are paid through or show up as a Part D claim versus only 14% of overall drugs. So they're very highly represented there. We talked about this before because of the USPSTF recommendations about about Hep C testing, et cetera, and the baby boomers having very high rates of Hep C for reasons we actually don't understand, which is fascinating to me. There's high rates of Hep C treatment in the Medicare population. And basically what they found is about $182 million went towards net revenue for manufacturers of these drugs, which was a 28% increase and came from a 74% decrease in healthcare organizations. There's an invited commentary which goes along with this, which tries to parse the 340B program a little more than I understand it. My understanding is just very clunky and complicated and leads to a lot of perverse incentives. And a lot of the, intent of the 340B program is good, but it's clunky.
So that's a lot of words, and I'm not sure I completely understood. Let me
neither.
see whether I can get it, which is that the manufacturers decreased the list price.
Yeah.
They ended up making more money because of an increase in sales, and revenues towards the dispensing organizations like hospitals went down. Yeah. That's the finding as I understand it.
Something like that, yeah.
And I'm going to tie this in a little bit to the Indiana trend paper that we just talked about, which is viral hepatitis is down, in part probably because of the availability in that time period of these antiviral drugs, which are really miraculous. And Louisiana, I think, just contracted with Gilead in another kind of healthcare reform move or pricing reform move to implement the so-called Netflix model of antivirals, which is you subscribe and you can use as much as you need in any given month for a 5-year period to see whether that reduces their costs and increases access. So that's off the grid with respect to these papers, but it's just it's an active area of investigation and innovation because drugs are so expensive, and we need to find ways to decrease costs and increase access.
Yep, and you just got to be careful when you use the word contracted, referring to infectious diseases.
Okay. Yes.
Next up,
Two more papers,
yeah,
right?
two more papers, then we're done. Or then House of God.
Yeah, bear with us.
Yeah, so this is a really interesting behavioral economics paper. They took patients who were overdue for colorectal cancer screening and randomized them to 3 different arms to motivate them to do colorectal cancer screening. So they basically either just sent them a mailer like, hey, get your screening, or a mailer with a $10 voucher, or a mailer with an incentive program with, I think it was a 1 in 10 chance of winning a $50 prize.
Mm-hmm.
The good news is there's about a modest 8% increase in fecal immunochemical testing, but overall there wasn't any major increase in colorectal cancer screening from this.
So that's my question. So this is one of these behavioral economics papers that we talk about, ways to use small amounts of money across populations to get them into healthier behaviors or motivate them to do things. The paper said, no effect on colorectal cancer screening, but completion of a fecal immunochemical test card is colorectal cancer screening. So I didn't quite understand that.
Yeah, and I thought maybe there was a small increase in a subgroup, but the colonoscopy group was bigger or something like that. And it actually wasn't. The colonoscopy group was actually much smaller,
Right.
but was I think a little bit negative.
Mm-hmm.
But the bottom line is just one of those things where there's maybe it's statistical noise or maybe it's just not enough to move the needle overall. But it's still, even 8% is not that big of an increase.
Yeah, no, that's true. But last I checked, there was randomized trial evidence for the effectiveness of FIT testing in terms of colorectal cancer screening, but there is still not an RCT of colonoscopy.
Really?
Yes.
I did not know that.
Correct me if I'm wrong, viewers, but there's still no large randomized RCT of colonoscopy. There's just all sorts of reasons, observational evidence, and otherwise the kind of the natural history of polyps to believe that colonoscopy is effective. It's also, despite the cost to entry, so to speak, psychological and otherwise, you get screened and then you can go 10 years. So it doesn't rely on adherence as much.
Yeah. Yeah. What's always interesting to me about colorectal cancer screening is how many lay people are like, oh no, I don't want a colonoscopy because of basically the fear of, bad sensations of stuff going up there. When really talking to anybody who's done it, it's the prep. It's the bowel prep that's terrible. You have to drink this gallon of polyethylene glycol, and then you spend a lot of time in the bathroom. And despite how much Americans focus on trying to spend time in the bathroom, they don't like this one.
Let's do our last paper.
Right. So this last one, I don't have a lot to say about it, but it's fascinating. So they looked at the risk of cancer among children and young adults with congenital heart disease, compared them with healthy controls. It was a great Scandinavian database paper. They had 22,000 kids with congenital heart disease versus 220,000 healthy controls in Sweden, or people without congenital heart disease, and found a 2-fold higher cancer risk in the patients with congenital heart disease. This is not the only paper to have found such a link, but this is a big database that's looking at it. One of the hypotheses they have to explain part of that difference is that the treatments for congenital heart disease have vastly improved over the last few decades. So a lot of these patients are reaching adulthood that used to not do that, and are also plugged into the healthcare system in kind of a strange way. So they're not necessarily getting screening tests, normal care that everybody else gets, because there's such a focus on the heart problems, which I found is fascinating as part of trying to tease out that mechanism. It's also possible just that, I'm totally making this up right now, but people with congenital problems have more congenital problems.
Well, right. So that's an obvious, at the most rudimentary, thoughtless level.
I'm very rudimentary and thoughtless. Thank you, Mike.
But if you look at that curve, they begin to separate in the first 10 years, and then just visually, for whatever it's worth, on those data, that delta seems to remain the same throughout the life course. So I'm not sure I see it as an ascertainment issue. These people are more connected to healthcare systems and therefore have more opportunities to have cancers detected, and or that treatments are improving and they're living to get cancers, because it's not only old age. The difference happens in early life also.
Right. We've got a couple new viewers, Julia and Dr. Peru. Thank you for joining us. We've got one last little segment. That's the end of our marathon slog through.
Don't make me wait. What's that last segment?
So, as you may be aware, the well-known book, The House of God, it's the 40th anniversary. JAMA is celebrating that in a bunch of different ways.
Tell viewers what the book is.
Okay, so The House of God is basically a book that it came out 40 years ago. It talked
1978 by Samuel Shem.
Yep. And it was basically a first-person look at an intern as he entered a mythical view, but most of it was actually pretty human and pretty positive. It's one of the things it's very well known for is the chief resident in medicine, un-PC-ly named the Fat Man, which is one of many un-PC parts of the book from News, a book 40 years ago, was not very PC. He had a bunch of laws about medicine. Some of them are quoted all the time still, like you can't find a fever if you don't take a temperature. My favorite is rule number 4, the patient is the one with the disease, which again, I think at first glance sounds pretty cynical and negative, but for me is actually really positive, especially in this era of wellness problems and burnout and things like that. And for me, when I'm having a rough day, when I'm in difficult patient encounters, especially I don't know, the kind of stuff that really wears us down, I like to remember that I'm the one who, I get to wear pajamas to work, I'm paid to be there, and I get to go home at the end of the day, and the patient's the one with the disease. And that helps me, I don't know, both revitalize myself and try to take good care of my patients, because after all, they are the one with the disease.
So check out the book, and what's our presentation here?
Oh, great. And there is so JAMA has a couple different papers coming out for it. There's 2 perspective pieces reflecting on it, correct? There's also a video that's going to be released tomorrow at 10 a.m. Central Time, which we're going to show the link shortener link right now. It's the JAMA.ma/House of God, and there's a YouTube video that will be released tomorrow at 10 a.m., which you should definitely watch. I'm very excited about it. Mike he doesn't show it, but he's very excited about it as well.
It's good. Watch it.
It just looks fantastic.
And sign up for, this is all publishing in JAMA, not in JAMA Network Open. So,
Yep.
check it out at JAMA.com, 10 a.m. tomorrow, and sign up for our emails.
Yep, usual stuff. Follow us on all the social media channels: Twitter, Facebook, Pinterest, YouTube, at JAMA Network Open. Join us next week, regular time, Monday, 2 p.m. Central Time.
And subscribe to our podcasts.
Yep.
See ya.
Take care.
Thanks for joining.